Hello and welcome to another episode of Onc Now, EMJ's Specialist Oncology podcast with me, your host, Dr. Jonathan Sackier. Today, I'm delighted to introduce Professor Janice Walshe. Professor Walshe is a consultant medical oncologist at St Vincent's University Hospital in Dublin, Ireland. As a key member of Cancer Trials Ireland, she's deeply involved in ensuring access to novel treatments for Irish women with breast cancer. She has led research in international breast cancer trials and served on ASCO's Scientific Programme Committee in triple-negative breast cancer for 3 years. As a senior lecturer at UCD and Trinity College in Dublin, she's published widely and serves on several oncology journal editorial boards. Outside of work, when she has free time, Janice enjoys reading, travelling, and staying active through yoga, Pilates, circuit training, and hiking. She's one fascinating lady, and I hope you enjoy the conversation with Professor Janice Walshe. So over to the podcast. So, Professor Janice Walshe, welcome to the podcast. Lovely to have you here.
So lovely to be here. Thanks for asking me.
So, and just before we jumped on, I was saying I've just booked some travel to go to Dublin. I love your city, and I love the vibe there. And I know that you like to travel. I always like to start gently before we leap into the science. What's your favorite destination that you visited, and what's on your bucket list to visit in the future?
Well, I think when you live in an island that you can drive from the north to the south in 6 hours and then go east to west in about 3, it is a place that is for sure beautiful and lots of good things, including lots of good food. But I think to travel is really the dream of most Irish people. So I've been very fortunate, I suppose, as a medical oncologist. I've got to see many, many cities. Probably my favorite is Italy. I love the north. I love the south. I love the people. I love the food. And probably my favorite place thus far is probably the Amalfi Coast. And believe it or not, even though I did my fellowship in the National Cancer Institute in Bethesda, Maryland, I saw very little outside of the US. So I never got to Canada. So currently on my current short-term bucket list, it is to get to Canada. Many of our fellows have gone over there to do fellowships, and they speak of many beautiful things and beautiful places. So that is where I'm going next.
Well, I worked in the States for many years, and I lived, everyone goes to Florida and California and New York. I lived in Virginia, sort of south of Bethesda. And Virginia, to me, is the most beautiful of the American states. And Montreal, go there, but don't go there in the wintertime.
Yes.
It's a new kind of cold.
Yes.
But in the spring and summer, it is just beautiful. And the autumn, of course.
And I need the warmth.
So I guess we all...
That's important.
I'm sorry, say again.
I need the warmth. Living in a cold island, I need to go to more warm. So I would not be going to Montreal at that particular time of year.
Absolutely. But the Jazz Festival in the summer's gorgeous. So, Janice, your paper, Real-World Analysis of Clinical and Economic Impact of 21-Gene Recurrence Score Testing in Early-Stage Breast Cancer in Ireland, highlights some important considerations for oncology care in the Emerald Isle. How do economic factors influence access to advanced diagnostic tools? And secondly, what steps can be taken to ensure that Irish patients benefit from the latest innovations in cancer treatment, and specifically in breast cancer?
Well, I suppose specifically, Ireland is a small country. We have a population in the south of about 5 million. We have a small tax base. Cancer care, as you know, is extremely expensive. So for us, particularly with this paper, where we published the impact of the 21-gene recurrence score in women who we've done it in 2 patient populations, although you've referenced one in patients who have node negative disease, so no lymph nodes affected under their arm, or those with node positive disease. And I suppose if to give context, I was in the NCI in 2005, and when Soon-Pake's paper came out, we had immediate access to that tool. And we were using it in the clinic on a day-to-day basis to make decisions about shared decisions with our patients as to whether chemotherapy was warranted or not. And when I came back to the States in 2006, we were back to clinical pathological factors. And I suppose what we would have said at that time was, look, we were over-treating too many patients. We believed that if we had access to tools like this, one, we would give much less patients the toxicity related to treatment. And number 2, that we would save money for the exchequer. And we would have lobbied the government at the same time that we were participating in the Taylor X trial, which was investigating the question, could we rely on this test to determine who needed chemotherapy or not? And in 2008, at the height of a financial crisis, as I'm sure you'll remember well, the government said, yes, we will give you access to this if you believe. Please audit this and tell us what kind of impact it makes. And this paper was really reflecting the fact that we saw a 70% reduction in chemotherapy administration in our node-negative population and a 50% reduction in our node-positive population, which of course has two huge effects. One, it reduces chemotherapy costs, but number two, it's a societal cost, right? The people that come out of work, the people who can't mind their children, the people who end up in hospital unnecessarily. So in a setting where we have a narrow tax base, saving money wherever we can is really important. We are very focused on that. Ireland is probably one of the slowest countries in Europe to approve drugs. We used to be faster than the UK. That has dramatically changed in more recent years. So for us, it's a constant fight to try and get access to drugs. We try, I suppose, and teach our government about the false economy, because we know that metastatic disease is both devastating but also extremely expensive. So if we can focus on drugs that improve survival, this will have cost savings in the long term. So those are the kind of considerations on a day-to-day basis. Now, the one thing I would say is it makes Ireland an excellent place to do business in, because we don't have a lot of access to these novel agents. We accrue mass numbers of patients to clinical trials, and we punch well above our weight in that regard.
Yeah, very much so. But, well, it's eloquently said. Sometimes getting through to the people who control the purse strings, getting them to understand that the cost to treat is the important thing over the lifetime of the patient. And of course, if the patient lives longer, then they may need additional treatments. But I think those of us in looking after our fellow human beings, that's the most important thing for us. So you co-authored a paper a couple of years back, retrospective observational study of HER2 immunohistochemistry in borderline breast cancer undergoing neoadjuvant therapy. Can you sort of summarize that and provide us with the state of the art?
So, as you know, HER2-positive breast cancer has a poor prognosis, and identifying patients who truly benefit from HER2-based therapies is really important. So, we've had various iterations of guidelines over time to try and determine who is HER2 positive, whose tumors are HER2 positive and whose are HER2 negative. And I suppose in the most recent ASCO-CAP guidelines in 2018, one particular group which were classified as HER2 positive previously were declassified then to HER2 negative. And these were patients whose tumours had immunohistochemistry 2+ for HER2. Their ratio was greater than or equal to 2.0, and their copy number was less than 4. So I suppose what we wanted to do as part of this paper, and it was a collaboration between the UK and Ireland, was to look at patients who had been treated with neoadjuvant chemotherapy, patients who had tumours that were HER2 positive by IHC 3+ and IHC 2+ in a range of different categories, but particularly focusing on this group that had been now allocated to be HER2 negative and therefore should not receive HER2 directed therapy. And what we looked at was the complete pathological response rate of these patients who had been treated with chemotherapy up front and then went to surgery, and looked at it in the categories of patients, particularly who were IHC 2+, who remained HER2 positive just because their copy number was maybe over 4, even though the ratio was exactly the same, or their ratio could have been less than 2.0, but their copy number over 6, and therefore classified HER2 positive. And essentially what we found was that the complete pathological response rate for those patients who had now been classified HER2 negative was 27%, higher than what we'd seen in groups that were already remaining as HER2 positive. Now, ASCO guidelines, as you know, have been updated recently. They stand by the 2018 guideline, so they have not changed that allocation. But what we wanted to highlight was that there were clearly patients within that group, albeit a small group, that probably do benefit from HER2 blockade. And the English guidelines continue to identify that at the moment. So they haven't declassified totally. They feel it should be part of the multidisciplinary discussion, whether HER2-directed therapy should be offered.
Thank you for that. So changing cancer types, if you will, invasive lobular carcinoma, I believe, represents around 10% or so of breast cancers. And please correct me if I'm wrong, but you published a 15-year look at this malignancy with clinico-pathologic profile and response to neoadjuvant chemotherapy. Can you summarize what you found, please? And first of all, is the incidence about what I said?
You're absolutely right. So it's about 10 to 15% of our breast cancers. There's a real spotlight on lobular carcinoma at the moment because we know that its response to treatment is very different. It tends to be more indolent, but the pattern of relapse can be different than what we see with invasive carcinoma, no special type, previously known as ductal carcinoma. So what we wanted to do through our study, we have a prospectively maintained database, was to look at our lobulars and particularly to look at the ones that we indicate as atypical lobulars, because as you're aware, the vast majority of lobular carcinoma tends to be hormone sensitive, HER2 negative, so ER positive, PR positive, HER2 negative. So within our study, we found over 500 patients, and within that, about just under 11% had what we deemed atypical lobular carcinoma. So these would be seen traditionally as triple negative lobular carcinoma or HER2 positive lobular carcinoma. And when we looked at those patients within that group who'd received neoadjuvant chemotherapy to downstage their tumour, the pathologic complete response rate was 15% in those patients who had atypical disease. So not terribly high, despite the fact they were HER2 amplified or triple negative, but certainly stark in comparison to the 0% of PCR we see in our typical lobulars, which of course is not surprising to us because these tend to be less chemosensitive. But also the outcomes of these atypical lobulars, our 5-year outcome was 83% versus 91% in the typical lobulars. So even within lobular carcinoma, which we see as a different entity, and I'm delighted to see that we're doing so much more work in that area, we see that the atypical lobulars within it aren't necessarily acting like triple negative or HER2 amplified in invasive ductal carcinoma.
Okay, right. So another aspect to your research has involved fertility preservation and assisted reproductive technologies, ARTs, in women with early hormone receptor positive breast cancer. Can you tell us a wee bit more about that research and some of the barriers these patients face?
You know, I think this has probably been one of the most important publications that we have put out. So this was a subgroup analysis of the positive trial. And the positive trial was an international collaboration looking at the feasibility and safety of women who have hormone-sensitive HER2 negative breast cancer, taking a break in endocrine therapy for up to 2 years to achieve pregnancy in the group of patients who have ER positive HER2 negative breast cancer. And they had to be on their anti-hormonal therapy for at least 18 months before they took that break. And we published the first analysis in the New England Journal in the end of 2023, which had shown compared to historical controls that the outcomes of these patients were the same, whether they took that break or not. So within that, we wanted to see, well, look, what was the impact for those who had engaged in assisted reproductive technologies? And about 36% of that patient group had done that. Now, it's important to say of that group of over 500 women, or around 500 women, you know, nearly 3/4 of them had achieved pregnancy, which is wonderful. But 36% had used assisted reproductive technologies. And many of those had gone on to use that to achieve pregnancy. And when we looked at the outcomes of those patients who had used assisted reproductive technologies, the outcomes, it did not affect prognosis, which is important. And also what it underscored was that these women were much more likely to achieve pregnancy having used that. So what it underscores for us is the importance of trying to get our women to freeze embryos or eggs before they start these treatments, to try and reserve that ability to have pregnancy later on. Now, obviously, the important bit is the decision to take that break is very much a discussion between the patient and the doctor, because it will be on the basis of the stage of the cancer and what the risk of disease recurrence is. So it's not for all patients, but at least we can say to them that, look, to take this temporary break appears safe.
Yeah. I guess it's another manifestation of personalized medicine, personalized medical care. Very, very interesting. Yeah, together with another guest who's been on our podcast, Donald Brennan, you published the MAC trial looking at multimodal technology-assisted intervention for the management of menopause after cancer to improve cancer-related quality of life. Obviously, very important work. Can you tell us about that work, please? I don't think I asked Donald about it.
So this was definitely his baby. It was the MAC study, Menopause After Cancer. And I suppose as a practicing oncologist, the one devastating part for many peri and premenopausal women is the induction of menopause to our cancer therapies. And the side effects of that can be very debilitating. I suppose the main ones we're thinking about are the vasomotor symptoms, the sleep disturbance, urinary symptoms, memory issues, emotional lability. And what we wanted to do through this study was a four-pronged approach to try and see if, one, we could reduce or improve cancer-related quality of life, and two, to investigate the changes in the frequency of vasomotor symptoms and sleep quality. And those four prongs were, number one, the use of non-hormonal pharmacotherapy, so such as citalopram, an antidepressant anti-anxiety medication that is well established to reduce the risk of hot flushes by 60 to 80%. Number two, the use of the Sleepio cognitive therapy app, which has been evaluated in about 14 randomized trials. It is NICE approved, and essentially it has a web-based sessions with an animated therapist, and they engage in these web sessions at least weekly. There's 6 different ones, and it looks at sleep hygiene, sleep restriction, cognitive therapy. And then the third prong of this was this My Patient Space app, which gave really simple instruction as to how to improve very common cancer symptoms, such as urinary symptoms and memory and stress, etc. And then last, there was the non-mandatory but encouraged involvement of a partner, because that was something that the patient advocacy groups felt very strongly about. And essentially what we saw was improved cancer-related quality of life using these ERTC scales at 6 months, about a 50% reduction in vasomotor symptoms, and a very significant improvement also insomnia, about a 50% improvement in reported insomnia. So this really seems to make a big difference. And we've been trying to incorporate these kind of measures into our clinic to help these women.
Yeah, again, I use the terminology that we're very good normally at treating the disease. We're sometimes not so good at treating the dis-ease that comes along with it. And it's wonderful to see this sort of holistic approach that you're bringing to cancer care. Actually, I have to say on this podcast, we've had some wonderful guests who've really opened my eyes, as I'm just a surgical technician, I guess you would say, but, understanding the totality of the care and removing the cancer or treating it with chemotherapy, that's just the start of the journey. So lovely. One of our guests, we talked about hypnotherapy, the role of hypnotherapy and meditation and yoga and all these sort of additional techniques that I really hadn't thought of. But
and very often we try and encourage all of those before patients end up in pharmaceutical stuff. There's evidence to suggest that it improves quality.
Yeah. Wonderful. So you've already talked about and done a nice little advertisement for come to Ireland. We're a great place to do business. Of course, your government are very good at encouraging companies to go there to set up. But from a clinical trials perspective, I know that you play a crucial role in Clinical Trials Ireland, ensuring access to novel treatment for breast cancer patients. Tell us about some of the trials that are ongoing now that have you excited and how they might lead to better patient care.
So this is probably, I see, one of my most important roles, because I need to try and get the best drugs we have in that look like are going to emerge as practice changing medication. There's a number I'm excited about. At the moment, we are waiting for the offsite trial to come in. that is one that is really looking at the 21 gene score in our pre and perimenopausal women. So far in node negative disease, there's kind of a hole insofar as if you have a score between 16 and 24 as a premenopausal woman with no nodes affected, there's this small but absolute benefit of chemotherapy and are as determined by that trial. The question is, could we achieve the same with ovarian ablation? So using the injections such as Olodex in combination with our endocrine therapy. So that's going to be examined in the offset trial. And in addition to that, it's also going to look at pre and perimenopausal women with no positive disease, because the RxPonder trial, which was reported out a couple of years ago, what we see is this small but absolute benefit of chemotherapy, regardless of the recurrence score of 0 to 25 in our pre and perimenopausal patients. So again, we're back into a scenario where we're over treating people. So we need to try and work out who are those that truly need it. So that is one that's upcoming. We're just working through, and we're hoping that's going to open shortly. We are actively accruing to the EMBER-4 trial that is investigating a switch mechanism from standard care endocrine therapy to these new novel SERDs, the selective estrogen receptor degraders. So women who've been on their endocrine therapy to 2 to 5 years, who are at high risk of disease recurrence, are randomized to standard care versus a swap over to immunosuppressant. And we have had a major accrual to that trial. Tolerability has been great. And it's going to be really interesting to see, will we overcome resistance to endocrine therapy by making that switch? So those are two, good ones we have at the moment. And we've contributed to many other questions.
And staying on the trial topic, you mentioned that you were in Bethesda at the NIH, which is undergoing some interesting challenges at this moment in time, which I don't think we're supposed to talk about politics, but I don't know how you cannot, frankly. You've been involved in numerous international trials and research projects. And I would say that from my career, it was one of the things that I enjoyed the most because of the collegial nature and the way that one's eyes could be opened. I was recently in China talking to some folks about actinium 225 treatments for metastatic breast and prostate cancer. I've loved that. Tell us about your experiences of international collaborations to advance breast cancer treatment and how it.
I couldn't agree with you more. It's the bit that gets me up in the morning. I mean, I suppose it would have been initially established by virtue of going to the NCI and looking at the way clinical trials are born and how they progress and watching it go through the various phases. My mentor at that time was Sandra Swain, who was a leader in breast cancer research. Through her, I was on the ASCO Scientific Committee for triple negative breast cancer between 2013 and 2015 and established many international collaborations as a result of that opportunity. And I've just gone on to be on a number of steering committees for trials such as the Affinity trial, the EMBER-4 trial, the Positive trial. And all of those have led me to contribute to moving the needle in terms of cancer progress and giving access for better treatment options for our patients. So it has been, a very fulfilling part of my career, the most fulfilling, I would say.
So I'd like to ask each guest, if you had 3 wishes, you have magical creatures in Ireland, maybe one of those magical creatures could provide you with 3 wishes for your area of healthcare. What might those be, Janice?
I think it is, 1, access to all clinical trials. Our difficulty is that we're up against places like France, Germany, Spain, where they have such a larger population. In Ireland, we have punched well above our weight. But I would like to be able to ensure that we got as many Irish opportunities for Irish patients that we could. 2, I would love infinite resources to allow to improve the patient journey, because it's tough. I need about 3 of me. We have a limited number of medical oncologists relative to our patient population. I probably see somewhere between 450 and 500 breast cancers a year. Really, that's huge. And if I were to say my third, I would love that as Europe, we could negotiate drug prices with the pharmaceutical companies, because probably one of my greatest frustrations is trying to get our drugs across the line. And if we could negotiate with the pharmaceutical companies as a large mass, we would probably achieve much more cost savings for our patients.
Wouldn't it be wonderful if there were no barriers to access? Sadly, that is all we have time for today, Janice, but I hope that this is going to be the first of many such conversations as you keep us informed about the wonderful progress you're making. So on behalf of the patients you look after, thank you for the work you have done and will do, and for taking the time to speak to us today. Also, thank you very much, Professor Janice Walshe. Real joy chatting with you.
It's been a delight. Thank you so much, Jonathan.
Well, I hope you enjoyed that episode of Onc Now, our bi-weekly podcast. If you did enjoy it, please consider subscribing on Apple Podcasts or Spotify or wherever you get your podcasts so you never miss an episode. And please like us on social media and tell your friends and colleagues. And check out our archives because they're growing. And please join us in 2 weeks for another fascinating episode. Until then, I'm your host, Dr. Jonathan Sackier. Please, everyone, stay safe, stay well, stay curious. Bye for now.